Paying attention to selecting the most appropriate test for profiling patients' tumors on a molecular level is critical in this day and age. And that's because we've really moved beyond single gene testing that we used to do in the early 2000s when we knew about fewer genes, like EGFR, for example, in 2003 and 2004, and then later the ALK rearrangement. Now we have a whole slew of other potential drivers like ROS1 and RET fusions, MET exon 14 alterations, BRAF V600E, and HER2. And so it's important to choose a test that's comprehensive and that's able to detect all of these alterations in patients who have non-small cell lung cancers. My personal preference is not to practice single gene testing anymore and to go for a multiplexed comprehensive approach. At our center, we use DNA-based next-generation sequencing, recognizing that not all NGS assays are the same. And of course, the caveats are that because it's a big test that looks for hundreds of genes, it can sometimes take a few weeks to come back. And for patients that are sick, it's critical to find out early on, maybe within the first week, whether or not those cancers harbor a driver. And so a strategy that we've adopted at our center is to do rapid phase testing where we look for EGFR and ALK using mutation-specific immunohistochemical antibodies, and that way you might get an answer within the first 1 to 2 days and be able to institute targeted therapy early. And then the rest of the sample we send for comprehensive NGS. So I think NGS is the way to go in this day and age.
Great.
The amount of time it takes for these assays to come back differs depending on the test. There are some good commercial assays that can come back within 3 weeks, for example. Then there are others that may take 4 or 5 weeks. But in general, you don't get an answer within the first 14 days, which is why it's important to either focus on rapid phase testing or also use a complementary approach like plasma-based cell-free DNA that can get you an answer within 7 to 10 days for some assays.
So the current standard of care in the United States is to perform genetic testing on newly diagnosed patients with advanced non-small cell lung cancer. We know that among patients with EGFR mutations, ALK, and ROS1 rearrangements, that these patients derive substantial benefits to treatment with the corresponding targeted therapies. So one would expect that based upon these benefits, that testing would be 100%. Unfortunately, that still isn't the case in the United States. And that could be for a variety of reasons. In speaking to my colleagues, many times patients who come to academic centers don't have comprehensive genetic profiling, and for a variety of reasons. Sometimes it can be because there's no tissue available. Biopsies were performed on, or fine needle aspirates were performed as the biopsy procedure, and there's limited tissue available to perform the corresponding genetic analysis. Sometimes patients don't have a disease that's accessible to a core needle biopsy for a variety of reasons. Nonetheless, I do think it should be our goal, and it should be the standard to perform genetic analyses on all newly diagnosed patients, and to do so expeditiously. For patients who don't have tissue available to perform genetic analyses, I think one can approach this in 2 different ways. The first is to actually repeat a biopsy. And I think if one has sufficient suspicion that a patient may have a targetable genetic alteration, that certainly makes sense, especially if a lesion is amenable to a repeat biopsy. We know that in patients who are never smokers, more than 50% of those patients are going to have a genetic alteration that can dramatically transform how those patients are managed. For patients who don't have disease that's amenable to a repeat biopsy, be it because of comorbidities or the location of their tumors, an emerging tool is actually to perform a liquid biopsy. So to look at circulating tumor DNA as a means to identify targetable genetic alterations. I think it should be emphasized, though, that liquid biopsies are not a substitute for baseline genetic sequencing if you actually have the tumor material available. Liquid biopsies can be a helpful complement, especially if the baseline tissue has been exhausted. The reason I say this is because circulating tumor DNA assays are not nearly as sensitive as doing genetic sequencing on a baseline tumor biopsy. And so a negative ctDNA assay isn't truly a negative test. It could just be that a patient isn't shedding. And so negative results on a ctDNA assay are really non-diagnostic. And you should keep an open mind that that patient may indeed actually still have a targetable genetic alteration.